Hello from Hannover. The goal of what I would like to do during the people have a little bit of possibilities to go to lunch is I would like to give an overview on acoustic implants and otosclerosis and our experience here in Hanover on some devices, and this is more from an audiological standpoint of view. So what we have, I've taken this graph from Cochlea, but I will talk about several devices and our experience here in Hanover. So you have on one axis, you have the sensorineural hearing loss, on the other one, the air bone gap. And as you can see here, that is with an air bone gap and a very less pronounced sensorineural hearing loss component. I will talk about the bone conduction implants we are using here. Where are the limitations about middle ear implants? I will not go into detail about the Met and the Carina too much in detail. We use that here, but there are reasons we have limited experiences here, and I will mention the working horses, the vibrant sound bridge in round window applications, and the CO-DACS. So that is what I would like to talk about. So as a short introduction, if you have seen the percutaneous systems that are using a screw and an abutment, very successful for a long time, very established. One of the solutions we have, and nowadays we have also some devices with magnetic transcutaneous systems, yeah, like the Baha Attract, and which is shown in the lower panel again with all its component, and the Sophono Alpha, which is implanted, a two-magnet system that is implanted to the skull, and on top, on the intact skin, adheres the hearing device. Now, we have some experience also with a bone bridge here as a bone conducting device. This is not a magnetic transmission, this is an electric transmission, like in the vibrant sound bridge. And the vibrator is an active device implanted to the skull. And this is one of the few surgical views I will show here. This is how it is implanted. And Rolf Seicher will talk about that later. So it's a not very small device, but a very successful device, especially because patients, if they see it, they have a tendency to prefer that. What are the limitations of those bone conduction devices? We have on one side, if we plot the hearing loss against the level for UCL and the threshold as HS, and the MCL, we see that with a hearing loss of 0 dB, we have an approximate dynamic range available in a normal hearing person between 100 decibel and 0 decibel. But this becomes narrower and narrower the more pronounced the hearing loss is. At 120 decibel, we have a dynamic range left from 120 decibel to 140 decibel, which is not enough to present speech adequately. And here the question comes up, what is necessary to understand speech? And according to Harvey and Dillon, this is 2/3 or 50% of the dynamic range are necessary to understand speech. In later works, that is by Swartenkot and Mertens, that is a fixed range is mentioned, which is 35 or 30 decibel. That is sufficient to understand sufficiently speech. If we plot that to the threshold, we see 35 in parallel to the threshold. So that gives the range that is necessary to understand speech. And we see that around 90 decibel, this is still 30 decibel, but above 90 decibel, the dynamic range is not sufficient anymore to understand speech. The other border we have, the other range is 30 decibel, and on this basis we can estimate what ranges are needed for a patient for a satisfying result to be implanted in hearing aids. Now, what are the maximum outputs? And I've taken a plot from Thorsten Rahne which shows how this can be determined. This goes back to the works of Mertens. So I apologize that this is in German, but the maximal output level is plotted there, and the input level is on the x-axis, and the y-axis is the loudness, what is the force level of the devices. And the experimental procedure is very easy. So the sound pressure is increased, and here plotted in this line is if it's increased the sound pressure level, but at where the restrictions of the devices start to apply, that is it is leveling off, and we have a maximum output level that can be not exceeded in those patients. And we can determine that experimentally either in patients directly or in artificial mastoids where we use the force pressure level. If we look at the available bone conducting devices and also hearing aids, we see that hearing aids are superior in case we don't have an additional air-bone gap. In case we have an additional air-bone gap, this degrades and it is less than what can be obtained even with the weakest devices. So this is a major restriction for conventional hearing aids. But if we look at the limitations for the different devices, which are listed on the right side here for the Baha Cordell, the Ponto, the BP 110, 110 Power Attract, and so on, the Bone Bridge and Sophono Alpha, which is the weakest device in all those, we see that the maximum output level does not exceed sometimes, can be in the range of 60 decibel. If we plot now the dynamic range and the 35 decibel limit, which is necessary to understand sufficiently speech, we see that we have an intersection, and that gives here, if we have the sensory hearing loss, that gives the maximum range in average results, and in some patients we have to look at that in more frequency specifically. But here this is here the average PTA up to 4 kilohertz is taken. We see that those devices here, for example, the Sophono is limited to hearing losses less than approximately 35 decibel. If we list that up, so the less conservative 30 decibel, we see that on the right side that the limits for the most bone conduction devices in terms of maximal hearing loss collected from different works listed below, you see that the Sophono is limited to sensory hearing loss components of less than 25, and if the less conservative range, the more conservative range is now taken, it's only limited to approximately 20 decibel. And we can see here that with the bone conducting devices, the maximum bone sensory hearing loss component, we can expect sufficient results in terms of speech intelligibility. We see they are limited to maximally with a Ponto with a Baha Cordell to approximately 50 decibel of hearing loss component. So those devices are limited in terms of what can be obtained. We see two other devices, the Sound Bridge and the CO-DACS, and I will go into detail and the Hannover experience on them in detail. So if we compare the stimulations, we have on one side, we have hearing aids that require an acoustic transmission over the chain, not in otosclerosis normally, but for less pronounced sensory hearing losses, this is also a possibility. We have the cochlear implants with an electrical stimulation, and we have two devices, bone conduction instruments with a mechanical stimulation to the bone, and we can stimulate either the ossicles or the cochlea directly via the round window membrane, or a piston in otosclerosis patients. So those devices directly mechanically stimulate the cochlea. What are the indication ranges of the concerning devices? The vibrant sound bridge at the incus, which is not an option, that is the indication range. This is limited by the company, as given by the company in the data sheet, is a little bit less if applied to the round window membrane. And if we take now the MET, the middle ear transducer by Otolaryngology, we see that this is going down up to 90 decibel. And we have the CO-DACS, which is designed specifically and for mixed hearing losses and directly not for sensory neural hearing losses. In the beginning, we see a range where that goes down to 80 decibel, but you will see that nowadays the specs are a little bit moved to higher hearing losses also. That was indication range that applied within the clinical trial. You have seen the vibrant sound bridge, just a short slide of the floating mass transducer that can be applied to the round window membrane. And if we look now at our results and what our experience is we can use it either directly to the round window, we can use it with a round window coupler, or we can use it with an oval window coupler, and I will come to that point a little bit later, how that may apply to otosclerosis patients if the stapes footplate is immobile. And if we look now, what are our experiences? We had a look on 126 patients and 107 cases. Some were bilaterally implanted, one was reimplanted, and we did a comparison with the same processor. All those patients wore the Amade sound processors and not the older ones. So we had a choice of, we compared the incus coupling, the round window coupling without a coupler, and the round window coupling with a coupler to the oval window coupling. And the reasons for implantation in this group was a mix of a lot of pathologies listed below. So first of all, how safe was that procedure? If you look at the bone conduction PTA before on the x-axis, and after surgeries on the y-axis, you see that they are all located around the 45-degree distribution of, and we don't see a lot of change in the conduction by the surgery. Only in oval windows, which you can see that some improve. We attribute that to either that we mobilize the stapes footplate or to the Carhart effect. But in general, this is it seems to be a safe procedure, and the bone conduction thresholds before and after the implantations are equivalent within the precision of the measurement. If we look at the functional gains we see, and the functional gain is computed here as a preoperative threshold to the postoperative threshold, you see that the incus coupling has the highest functional gain. You see, that the round window coupler coupling with a coupler has the highest functional gain at mid frequencies. The incus coupling is a little bit below because here the middle ear is not circumvented and not air bone gap is substituted. If you look on the right side, what are the average values? The best still is the incus coupling, the most predictable, but then we have the round window coupling, and the results we obtain with the mean word recognition scores are around. The median are around 90% with the coupler. We see that in round window coupling without the couplers, we have a broad range of results, and also this is true for the oval window coupler. But this is true, that is only for mobile stapes plates. If we now look a little bit how our results, word recognition results distributed as a function of the average sensory hearing loss component before surgery, we see that we obtain a very steep descent for the incus coupling, and we have some results at the border around, above a border of around 48 decibel, which are less than 50%. This is also true for the oval window coupler, where we have a steep decrease at around 50 decibel. And we see that the round window coupling without the coupler is more forgiving, and we even have some better results at higher losses, inner ear losses, and we see that using the coupler improves that a lot. So nearly all patients were above 50%, and we see even at very pronounced inner ear losses, we see that we have results with word recognition scores of more than 50%. I shortly mentioned that we used the oval window coupling. We also used the oval window coupler going through the stapes footplate. And as you can see in word recognition scores, unaided before the surgeries, those 6 patients we implanted with an oval window coupler going through the stapes footplate, using it as a pistons, and with some cartilage as interposition, we obtained, before surgery, we had, people were at 65, had a nearly 0% word recognition score, which went up to above 90% at average, and even at 80 decibel, patients were in the ceiling effect. So this is a possibility for the future, and we are currently investigating how this can be improved and established. One of the other working tools here in Hanover is the cochlear, the CO-DACS, direct acoustic cochlear implant, which is a piston driven by an actuator, and which goes through a stapedotomy. And this current actuator is intended for severe to profound mixed hearing loss, especially otosclerosis, and I will show results on otolaryngology. We started, some of the patients were implanted within the clinical trial and with a very more conservative indication range between 40 and 80 decibel, but nowadays the indication range of the device goes down to 90 decibel at 2 kilohertz. So very pronounced, even very pronounced sensible hearing loss components. This is a result during the clinical trial out of 12 patients, and we did a comparison in blue of the aided thresholds in sound field of the patients. You see air conduction of the patients at average were close to the measurement limit of the audiometers we had, and some of them were even exceeding that, and we estimated their thresholds by adding an increment of 5 decibel. So, but in some patients, those thresholds were not measurable. What we achieved as aided thresholds with conventional hearing aids is shown in blue, and the CO-DACS results were superior as blue, as you can see in the aided thresholds after surgery for patients. We are sometime later after that trial, and out of 29 patients we have implanted in otosclerosis patients with immobile foot plates. Now we have, you see on the left side, you see the word recognition scores with hearing aids preoperatively not available. On the left, on the y-axis, shows those patients who were unable or not willing to wear hearing aids. So we only have the post-operative data available. But you see that in nearly all patients, the word recognition scores in monosyllables were better with scores than preoperative with a hearing aid. And we also are hearing a noise. You see better, minus is better. You see the patients who could not wear hearing aids, and you see that this hearing in noise improved aids in all patients, or remained the same in one patient, or was worse only one patient, but all patients except this patient I showed improved by the CO-DACS compared to the hearing preoperatively. And this data is measured 5 months post-operatively. And pure tones, this seems to be a safe procedure, as you can see. Astonishingly, we see that the BC thresholds improved slightly as a trend, not significantly, by the surgeries, and our guess is that this is to the Carhart effect, that we opened an immobile stapes footplate. If we monitor that over longer terms, now we have some data available. As you can see, the monitoring, the audiograms on the left side follow the audiograms you have seen before in 19 patients, 3 months post-op. And they don't change delta BC after 2 years, so they are nearly unchanged. And after 4 years in 6 patients we have now available, the data is nearly the same as before the surgery. So we have a slight decline, but nothing at average, at higher frequencies. But after 4 years, we don't see a pronounced trend in either direction. So even that procedure seems to be a safe procedure. Another measure to monitor the same thing are the internal thresholds measured with the device. And you can see at 2 years and at 4 years with 5 patients, the direct thresholds were unchanged after 4 years compared to preoperatively. So also long-term data now is available for speech recognition in quiet Freiburg monosyllables, again at 65 decibel presenters. The word recognition, the median is around 80 decibel and stays the same within the precision of the measurements till the limit we have now for 6 patients at 4 years after surgery. So there seems nothing to happen on long term to word understanding, and the same is true for the speech in noise measured with the ALSA, noise coming from the front and speech coming from the front. We see in the huge cohort at the beginning, at 3 months at activation, and we have only 3 patients available for this test. After 4 years, we see not a pronounced trend in either direction. So we even see something like an improvement. So those patients seem to adapt to the device, but it's too early to verify that trend statistically. Interestingly, the other border is if we compare those patients, the CO-DACS patients, we have an indication limit of 90 decibel at 2 kilohertz. So we are in a range where also we have to take into account that a cochlear implant may apply. And we did a study, we compared 25 CO-DACS patients with otosclerosis with BC better than 85 decibel, and the average PTA was around 60 decibel, 3 months post-implantation. And we choose from our files 25 matched CI patients implanted for various reasons, usually with an airborne gap, and which were better than 85, had a cochlear reserve and a bone conduction thresholds better than 85 decibels at average, and compared them with results 2 years after implantation, where cochlear implants shall be at a steady state already. If we look at now in green with the CO-DACS patients, here there's median values for bins of 10 decibel, 40 to 50. This is the median of 50 to 60, and this is the median 60 to 70. We had no patients with a PTA above 70 decibel in that group up to now, but you can see that in blue here, the medians of the cochlear implant patients 2 years after activations are not too different. Even if we have for a decent cochlear reserve, we have a significance of 5% in that group, but with a more pronounced hearing loss, there is no difference at median. The only thing that is remarkable is that none of the patients with the CO-DACS shown in green was less than 50% of word recognition score, even with the most pronounced hearing loss. So it's a predictable results. If we now look at hearing in noise tested with a test for cochlear implantees, we see also shown in green for the same bins here in 10 dB groups here. We see the median value is nearly 90% for those patients with a CO-DACS with the least pronounced for inner ear loss. And it has a slight tendency of down to higher losses, but hearing in noise is far better what is seen in cochlear implant patients. And the other advantage is that our experience shows that if a patient is implanted with a CO-DACS, it is after implantation, it behaves more or less like a hearing aid. And after 3 months, patients have adapted to that. That is the reason we have used the 3-month data for the CO-DACS and the steady state level for the cochlear implants. So hearing in noise is superior with the CO-DACS compared to cochlear implants and seems to be a better option for otosclerosis patients. As last, I would like to show one example. This is a patient who was implanted in 2013. That is a patient who didn't want to participate in the trial. So he was implanted with a cochlear implant in 2013. The average bone conduction PTA was 55 decibel, and the results obtained in monosyllables were 60%, and hearing in noise was around 20% in this patient with a cochlear implant. But this patient was implanted with a CO-DACS on the second side when it was commercially available. And as you can see, the BC PTA is marginally better than on the contralateral side. And after 3 months after implantation, the patient was able to understand 80% of Freiburg monosyllables, and hearing in noise was much better. So even that example illustrates that the statistics I've shown before do apply. Today we have some patients which are bimodally implanted with a CO-DACS and a CI, and if we look on the cochlear implant side, on thresholds, they are nearly equal. For one patient it was not available, so they are comparable on both sides, more or less. And if we look at the word recognition scores, all 4 patients scored better at 65 decibel with a CO-DACS than with a cochlear implant. And if we look at in hearing in noise, all patients scored much better with a CO-DACS than with a cochlear implant. So this seems to be an advantage of the CO-DACS implantation, this hearing in noise, and the adaptation to the device seems to be much easier than for cochlear implants. In summary, bone conduction implants are possible, but limited by the maximum output, and the maximum output limits also the estimated time of use. So those patients are also underlying a presbyocusis, so the time of use is also connected to the maximum output and the adjustment of the device to the presbyocusis. The vibrant sound bridge at the round window has a higher maximum output. It has some variability in results, and we are working experimentally on that. And there are concepts. And the CO-DACS is not limited by the maximum output because it lies about UCLs. The maximum output is above the UCLs of all patients, and it is an alternative to cochlear implantation. And as you could see, we went up to a PTA of 70 decibel, so the indication range is not fully explored up to now. And I would like to thank you for your attention, and I also would like to thank for my co-workers, which are listed on the right side. Thank you.